Hi everyone, this is Julie. We're having a little technical issue, but we're going to get started here in just a few minutes once we can get the lines unmuted. Thanks.
Thank you, everyone. I apologize. Can you hear me?
Yes.
Perfect. Thank you. Again, thank you, everyone, for your patience today. A little technical difficulties, of course, to start our day. Hi, my name is Tiara Brooks, and here at School-Based Health Alliance, we are excited to have partnered with the National Healthcare for Homeless Council, and would like to thank everyone for attending today's webinar titled Trauma and Homeless Youth. This webinar will describe the connection between homelessness and trauma and the effects on children, trauma-informed practices, and additional resources. But before we begin, we have a few housekeeping reminders. First, please help us with our attendance count. If you are viewing as a group, please go to the question box and type in the name of the person registered and the total number of additional people in the room. For example, Tammy Jones plus 3. This will help us with our final attendance count. Also, all attendees are in listen-only mode. However, we want to hear your questions. To ask a question at any point during the webinar, please use the question box located in your GoToWebinar control window. We will address questions following the presentation. At the end of this webinar, attendees will be asked to complete evaluation poll questions. Please let us know how we are doing. Your feedback is vital in helping us craft presentations that meet your needs. This webinar is being recorded and will be archived on our website in 3 to 5 business days. Please also visit School-Based Health Alliance for additional archived webinars for topics such as the ones you are viewing on your screen. It's almost that time. The 2016 National School-Based Healthcare Convention in Raleigh will be held in Arlington, Virginia, June 26th through the 29th, 2016. We hope you'll join us for another year of innovative workshops and engaging speakers. Registration is now open. Please join us and register today. The School-Based Health Alliance works to improve the health status of children and youth by advancing and advocating for school-based health care. Our members extend and support our work. We offer 2 options for memberships. Our members receive exclusive access to valuable program tools, timely publications, networking opportunities, and yes, including discounts to our 2016 convention. Please take a moment after the presentation to visit our website for additional information. Now I would like to introduce our presenters today. Julie Hashida is a project manager for the National Healthcare for the Homeless Council. Julie has served the Council's Clinicians Network, staffing the steering committee, working on the Youth Engagement Project, and engaging homeless youth work group. Her formal education is in clinical mental health counseling with additional training in trauma, play therapy, and substance use disorders. In addition to organizing trainings and developing educational products for the Council, Julie provides direct service in the form of crisis counseling for family and children's services in Nashville, Tennessee. Our next presenter, Erica Torres, is the director of the Center for the Vulnerable Child at UCSF Benioff Children's Hospital, Oakland. The CBC works to promote the health and social welfare of children, youth, and families who are in transitional living situations, including homelessness or foster care. Dr. Torres is passionate about providing culturally responsive care to children, youth, and families who are multi-stressed, marginalized, underserved, and underrepresented. More recently, she has focused on improving the integration of behavioral health into healthcare by the way of implementing behavioral health programs in primary care and advocating for mental health issues on a local and regional level. I would now like to turn it over to our first presenter, Julie Hashida.
Great, thank you, Tiara. I am trying to share my screen right now, so hopefully you all can see it.
Yes.
Okay, all right. So here's what Erica and I will cover in today's presentation. I will start off with defining homelessness, culture of youth homelessness, which really looks at the pathways to homelessness and subgroups and subpopulations. We'll touch on challenges of engagement, and then I'll hand it to Erica to go over the trauma-informed care and treatment for trauma piece. At this point, we have two poll questions, so I'm going to give it back to Tiara to pull up those polls for us.
Yes, our first question is for everyone. What role do you play at your healthcare? If you can please take just a minute or so just to answer this question, please. Okay, one more second. All right, thank you, everyone. So Erica and Julie, we have direct service provider 28%, outreach worker 11%, administrator 21%, front desk or receptionist 1%, and other 39%. For those of you that did mark other, if you can please put in the question box, what role do you play in Health Center if we did not provide that for you? And our next poll question that we would like to share is please select the option that best describes you. If we can take a minute or so to answer the question, thank you. Okay, a couple more seconds. Okay, so we have 36% said I have a little to no training on trauma, 48% I have a moderate amount of training, 16% extensive training, and 1% they're an expert.
Great, thank you so much.
You're
Are
welcome.
you able to see my screen?
We are.
Okay, so I'm going to, okay, how about now? All right. So we'll start with defining and determining housing status and why this is important. So there's a good chance that many of us who have worked with children in our schools and or health clinics were experiencing homelessness, and we did not address their housing status as part of their health care, because maybe we did not know that they were experiencing homelessness, or we did not know how to incorporate their housing status in their services or treatment plan. And this is important because once we determine housing status, we can address any related barriers to care. We know that adhering to treatment regimens, making it to annual checkups when there's nothing that seems wrong with us, or even making it to follow-up appointments can be difficult and maybe not a priority for someone experiencing homelessness, a priority over meeting basic needs such as securing food or stable and safe housing. Medications that have to be refrigerated might be an issue for people, especially if they're living on the streets or in their cars, or even some shelter programs where they don't have access to refrigeration for those medications. It's going to make that difficult. So there's some things that we need to consider when we're providing medical care and other services to this population. Homelessness exacerbates health issues. Homelessness and healthcare are part of a transactional cycle, meaning housing stability can be influenced by someone's health issues. That can include addiction, mental illness, trauma, or some exposure to violence. And then these health issues are exacerbated by not having a stable, safe place to live, and more so in cases when people don't have appropriate resources and support. And taking all this into account, we look at the target population of young people. So young people are at a critical time of growth and development, not only physically, but cognitively, emotionally, and socially. And in many cases, if not all, homelessness in itself is considered a traumatic event. A little later in the presentation, we'll look at in detail how trauma actually affects individuals' brain and development and their behaviors. But many times people who are experiencing homelessness have experienced more than one traumatic event. And what we learned through the ACEs, or the Adverse Childhood Experiences study, is that there is a relationship between the number of traumatic events that a child experiences and negative long-term health outcomes. So we need to be addressing barriers to care and also providing holistic and trauma-informed care. And then lastly, as far as why it's important to determine housing status is more administrative, but clinics that are part of the Federal Health Center program are required to report annually through their uniform data system, the UDS, the number of clients that they serve who are experiencing homelessness. If you're receiving the Healthcare for the Homeless grant, you would have to disaggregate that data and into the types of homelessness for the UDS. But if you're not receiving that grant, then you would just report on the total number of your client population. For program administrators, it's critical to use your grants and funding as it's intended. So although these programs may be funded to serve people experiencing homelessness, the definition and eligibility criteria may differ depending on your funding agency. HHS definition includes the term living situations that are quote unquote unstable or non-permanent. And then HUD recently came out with guidance on determining homeless status specifically for youth for their COCs or continuum of care and their emergency solutions grant programs. So we want to serve as many people as we can, and we also don't want to risk losing funding. So we always encourage programs to defer to their funding agencies and consult with technical assistance organizations like the Council and with any concerns about eligibility for programs serving people who are experiencing homelessness. Listed on this slide are just some examples and of types and definitions of homelessness. So the first is public and private facility that provides temporary accommodations, such as shelters, and that's including domestic violence shelters, transitional housing programs. And that one is also related to that last bullet point on permanent supportive housing. So, or PSH. So if you're receiving funding through the Federal Health Center program, there's HRSA language and policies that help show that people who are living in permanent supportive housing are eligible for homeless services. We also see folks living on the streets. Some programs are funded to care for people who are at risk of homelessness or who have been homeless and have been recently housed or are newly housed. Single room occupancy facilities, or SROs, we don't hear or see too many of those much these days, but they still exist. And people also will live in abandoned buildings. They will double up, which is one form of hidden homelessness. Doubling up, there's not an exact definition, but this is when individuals are staying with their families or staying with friends, generally as a result of losing their housing or some type of crisis. But the doubling up is a situation that they mean to be temporary. So we know that there are cultures and families that cohabitate, and that's meant to be permanent for them. So in that situation, that would not be doubling up for the purposes of defining homelessness. We see a lot of older youth couch surfing. Folks will sleep in their cars, will camp for an indefinite amount of time. And then we do like this kind of broad guideline around unstable or non-permanent situations to qualify people for our programs. Assessing or determining housing status. Whether we ask these questions in person or on paper, it really requires us to ask it in a sensitive and non-threatening manner. And it's important to note here that using intake forms by itself is generally not enough to make that final determination of housing status. And just because people include an address doesn't mean that they are not experiencing homelessness or are not eligible for services through your homeless programs. So because if someone is staying at the local mission, they may use that address, or they may use the address of their friends if they're doubling up. And then young folks who've been kicked out of their parents' house, they will still use their parents' address on these types of forms. So just because they write down an address should not help us in making that determination. On intake forms, we've seen programs ask directly, are you currently experiencing homelessness? And this can be problematic because if people feel ashamed or embarrassed about their situation, they may not self-disclose. And also people might not think that sleeping on the streets, or might think that sleeping on the streets is the only form of homelessness. So knowing this, that should really affect how we assess for status, but also how we do our outreach and marketing our programs and services. So instead of asking that question like that directly, are you currently experiencing homelessness, we recommend instead asking, where did you sleep last night? And if you have this on an intake form, you can create a checkbox, a list of options. Some things you could put on there would be with a friend. You could find out the names of the local domestic violence or intimate partner violence shelters in your area and list the names of those programs there. You could write in my car, at the mission, camping, and then again identifying the local permanent supportive housing programs in your area. Another thing to consider in assessing for status is the frequency. So again, we defer back to your funding agencies, but some programs may assess every visit, or once a year or every 6 months. So that's a conversation to have with your staff, and again, refer back to your funding agency. Following an intake form, you can have an eligibility worker, a case worker, case manager, or some other intake specialist that can follow up with these questions to assess for status. And they can ask, where are you staying? How long have you been there? How many times have you moved in the last year? And these are sensitive ways to ask a question and to make that determination. And again, these are just some considerations. So the council's happy to work with you and your clinic to review intake forms and to provide peer guidance and technical assistance on how to improve your forms and intake process. In providing culturally appropriate care, we also want to incorporate pathways and pathways to homelessness and subgroups. Youth's pathway to homelessness may be attributed to a single factor or combination of factors, and you'll see some of those examples listed on the slide. In providing culturally appropriate care, service providers need to recognize how their consumers' stories and their backgrounds affect their here and now experience. Subgroups and subpopulations of homeless youth can overlap with the concept of pathways to homelessness, but these are unique circumstances and characteristics of the individual's experience. And then some examples are listed on the right side of your screen. And of course, folks can fall into multiple subgroups or subpopulations. So just like how experiencing homelessness can act as a barrier to care, there are special considerations that we need to address when working with these special groups. In addition to these two concepts, the United States Interagency Council on Homelessness created the Youth Framework Model, and it suggests that organizations consider an individual's time experiencing homelessness, so whether they're newly homeless or chronically homeless, because this categorization correlates with both high and low risk factors for long-term problem outcomes. We also need to touch on and address the potential challenges to engagement. These include rigid agency policies, so programs might have strict rules and expectations that may be unnecessary and more act as a barrier for youth who are trying to access your services. So we kind of need to check ourselves and make sure we're not getting in the way of getting in our own way of providing care to those who we are meant to serve. As far as the law, legal issues include age of consent for health care, which we see a lot with those who are unaccompanied versus accompanied youth. And then if you have any housing programs, the age to sign a lease can become a barrier. For the young folks that are under the age of 18, criminalizing of status offenses will be a challenge to address. And then lastly, the lack of documentation. So lack of having an ID, driver's license, or birth certificate, that might become a barrier to accessing care at your clinic. But the National Law Center on Homelessness and Poverty does a lot of work to address these topics, and I would recommend checking out their website for more resources on those issues. Substance use is a challenge for a few reasons. First, youth may automatically assume that just because they use, they would not qualify or be accepted into programs, or that they might get caught and get punished for using. So they may not even attempt to try to access services. And then because shame and guilt are a huge part of addiction, youth who do have relationships with your providers may not want to disappoint them, and they might withhold information or just totally stay away from programs while they're using or until they get sober. So to address this challenge, we encourage all levels of staff to be trained on models of motivational interviewing, harm reduction, and other non-judgmental approaches. Youth may perceive, so the next bullet point, perception of adults. Youth may perceive the healthcare system, the service providers, just older adults in general as non-trustworthy or untrustworthy. And this may be due to many factors, including past traumatic events. So relationship building and trauma-informed practices are essential for that reason. Knowledge of available services or eligibility for services is especially for individuals who are experiencing homelessness for the first time or they're newly homeless. There might be a lack of knowledge as far as what services and assistance are available to them. So this is, again, where outreach and marketing and having strong community collaborations and partnerships are going to be necessary. What all programs can probably attest to is the lack of agency resources as a challenge. So we may not have the physical space, the number of well-trained staff, or just general financial resources to address and meet the needs of our community's youth. And lastly, living in rural areas affects engagement because of, mostly because of lack of community resources. But again, that's just a special subgroup, subpopulation that has other needs that we need to look at if you're living and serving that population. So we're going to switch gears now. Listed here are the guiding principles for trauma-informed approach that was developed by the Substance Abuse Mental Health Services Administration, or SAMHSA. And Erica will actually share how programs can tailor their practices and policies to align with these principles. For anyone working in this field and working toward becoming more trauma-informed, whether that's as an individual service provider or clinician, or if you're trying to transform your organization and even hopefully your community, the first step is training in what trauma is and how it affects us. But at this point, I'm going to turn it over to Erica.
Hi, I'm just switching it over to my screen. Thank you, Julie. Is my screen showing, Julie?
Yes.
Okay, great. Thank you. And I wanted to start with just a brief introduction of the work that we're doing at the Center for the Vulnerable Child, so you all get a sense of who is talking. And the Center for the Vulnerable Child at UCSF Benioff Children's Hospital, Oakland, is a designated federally qualified health center. And we have a Section 330H grant that serves children, youth, and families in medically underserved areas of Oakland. And the CVC serves about 3,000 children and youth per year, and we provide school-based, home-based, and community-based services. And UCSF Benioff Children's Hospital Oakland is also a partnering agency of Trauma Transformed, or T-Squared, and this is a regional center and clearinghouse in the San Francisco Bay Area that promotes a trauma-informed system. The goal of Trauma Transformed is to centralize and build a regional trauma-informed system of care, which ultimately improves the ways that we understand, respond to, and heal trauma. We have 2 school-based health centers at the CVC, and they are located in East and West Oakland, the Youth Uprising Castlemont Health Clinic, and the Chappelle Hayes Health Center at McClymonds High School. They're school-based outpatient clinics established in coordination with Oakland Unified School District. Both of our centers provide comprehensive integrated medical and mental health services that support long-term health and wellness of teens and young adults. And our staff at our school-based health centers work really hard to create a non-judgmental, youth-centered, and confidential environment. Some of the services include comprehensive medical services, individual, family, and group therapy, crisis intervention, and most often the treatment of trauma, depression, anxiety, stress, and grief and loss. And in addition to the center staff offers mental health consultation and professional development for the educators in our school system, as well as health education on topics like nutrition, self-care, healthy lifestyles, conflict resolution, reproductive health, and substance abuse prevention. So I wanted to start with a brief overview of trauma to make sure we all have a shared language and understanding of it. I know that we have a broad range of folks in our audience who have a broad range of experience and knowledge of trauma. So those of you who are experts, please bear with me. So this definition of trauma that I'm using comes from SAMHSA and a number of trauma experts, including Judy Herman, Bessel van der Kolk, Dan Siegel, and some others. And this definition is a basic definition which basically outlines that there is an event that occurs, and in that event the individual has an experience of the event, and then there is the effect. And the event or circumstances may include the actual or extreme threat of a physical or psychological harm. This can also include severe life-threatening neglect for a child that impacts their development. And these events may occur once or repeatedly over time. The individual's experience of the event helps us to determine whether it is a traumatic event. When we're under threat, our brains and bodies mobilize into a fight, flight, or freeze response. And this response is really about survival. The difference with trauma is that this typically normal stress response is coupled with powerlessness, hopelessness, or an inability to escape. And when this happens, our brain and body become overwhelmed. And this leads to a disintegration of the parts of our brain and body that normally work well together. This then leads to a dysregulation, which is a loss in capacity to modulate our internal states, including stress arousal and our emotional states. And this is what can have lasting adverse effects. These effects may occur immediately or may have a delayed onset and can be short or long term. So some examples, and we'll get into this a little bit later, are an individual's inability to cope with the normal stresses and strains of daily living, youth's inability to trust and benefit from relationships, and an inability to control the expression of emotions. So I want to back up and provide some basic neurobiology. So how many of you remember the term neurons that fire together, wire together? Our brain and the rest of our nervous system is made up of a network of neurons that connect to each other. And each time a connection is made, that connection becomes stronger. This is how any of us, or how any of what we do becomes automatic. It's how we form habits. So for example, if you're trying to learn an instrument, let's say a guitar, at first you need to think of each and every movement of each finger for each note. But each time you do it, a neural network fires. And as you practice, those connections between the neurons become stronger. Then you can add more complexity, another hand, more rhythm, etc. And after practicing over and over, you can play a song without having to think about it at all, or having to think through each and every movement or note. Practice makes perfect. It's how we learn anything, cognitive, emotional, or physical. This is an important fundamental concept, as it helps us to explain what happens to us when we're exposed to chronic trauma. And it also helps us to explain how we can help rewire the brains and nervous systems of children and youth who have been exposed to chronic trauma. So here's a little bit more about what's going on in the brain. So I'm going to ask you to participate with me. So let's make a fist and imagine that this is the brain. So if you're looking at your fist, the lower part of your hand and the wrist is your brainstem. The thumb is the midbrain, and this is where the limbic system is. This is the part of our brain that stores memories, it mediates emotion, it acts in a fast and sometimes decontextualized way. These parts of the brain, the brainstem and the limbic system, are what we call the survival or the emotional brain. Now, fold your fingers over your thumb. And this is the thinking brain. the part of the brain that is involved in rational thinking, planning, organizing, problem solving, prioritizing where I'm placing my attention. In the healthiest of circumstances, when we're safe, all of these parts work together in an integrated way. But when we're under threat, we go into fight, flight, or freeze, into survival mode, and the survival brain takes over. So pull out your thumb from under your fingers and wiggle your thumb. And here's what scientists found out when they put people who have experienced chronic danger and threat into a brain scan. When they trigger the person with a trauma reminder, it could be a certain sound, an image, a smell. What happens is, even when the person is not actually in any danger, is the thinking brain largely goes offline. The survival brain takes over, and the brain and body behave as if the past trauma is happening all over again right now. So just wiggle your palm and your hand and imagine that that's the brain going offline. So this next slide talks about how trauma impacts behavior. We see children use, anyone who's experienced trauma, express inappropriate behaviors. They have failure to understand directions. They may overreact. They may be hypervigilant. They may react aggressively. They may have difficulty connecting cause and effect, perfectionism, depression, anxiety, self-destructive behaviors, and fear and vulnerability. This next slide talks about some of the challenges faced. So inability to process information, we'll talk about that in a couple of slides. Unable to meaningfully distinguish between threatening and non-threatening situations. Difficulty forming trusting relationships with adults and modulating emotions. Trauma can have an impact on our memory, an inability to encode, process, and store information. And this can impact both our unconscious and conscious storage systems, which then impacts our recall and recognition. So imagine how this is all impacting youth's capacity to attend in the classroom in school. So I'm going to talk quickly about another metaphor that helps us remember what happens to a person who has been knocked into the survival brain. It's of a rider, and it's of a rider on a horse. And I actually first heard this from Bessel van der Kolk. So the thinking brain is the rider, and the rider sits up high, makes informed, rational decisions, and they can use verbal language to communicate. The survival brain is the horse. The horse is very strong. It acts on protective instincts based on feelings. And when the rider and horse are working together, they can get pretty far. They do lots of productive work. So if you got a person in front of you who has been triggered into survival brain, say they're yelling, they're screaming, they're looking like they're going to throw something at you, there's no amount of complicated verbal explanations about why they shouldn't be so upset, offering them a form to lodge a complaint, threats of consequences if they don't calm down. None of that is going to help the situation, because at this point you're talking to the part of the brain that is a terrified and nonverbal creature, the freaked out horse. And just like if you suddenly found yourself in front of a terrified horse, would you yell? Would you gesticulate? Would you get up in the horse's face? No, of course not. You would get kicked, and possibly rightfully so. So once we recognize what's happening as a fear response, we instinctively know to lower the register of our voice. We know to talk slowly and calmly. They're not necessarily even hearing the words, but they may be processing our nonverbal communication and body language. We move slowly and predictably. We don't approach suddenly. We do whatever we can to help the person in front of us feel safe, not trapped, and a little bit more control, and ultimately to help them calm down so that their rider can get back on their horse. Once their rider is off the horse, then you can, or no, I'm sorry, once their rider is on the horse, then you can think together about what needs to happen next. And by the way, this doesn't only happen to our clients or other people. It can happen to us too. And ultimately, it's better not to make any big decisions or do anything irrevocable if our riders are off our horses. So now let's move into trauma-informed care. And trauma-impacted individuals, as we've been talking about, may try to solve this human dilemma in ways that can be disturbing to others. They may engage in drugs and alcohol use, risk-taking behaviors, self-injurious behaviors, compulsive stealing, aggression, problematic sexual behaviors, or sexual behaviors that put them in harm's way. And when we see this in others, we can have lots of negative judgments about them. These behaviors tend to get people in trouble rather than getting them help. And when we see this, rather than asking, what's wrong with you, can we ask, what has happened to you? Is it possible that this is just an unskillful attempt to get rid of the fight, flight, freeze feeling? And by the way, who among us does none of these things ever? If we don't do these things, it's probably because we don't have to, because we got handed a different deck of cards than someone who does do these things. And in the end, we're all doing the best we can with the deck of cards that we've been handed. When we approach people with this understanding, we're in a much better headspace to be able to contribute towards healing rather than inadvertently contributing towards harm. So we see trauma-informed care as, number one, as a provider, agency, and community response. We see it as the importance of training staff and clients around developing a shared knowledge about trauma and its effects. We see the importance of developing an assessment of policies and practices to ensure that we are creating an environment and physical space that's truly responsive to the individual who has experienced trauma. And in July 2014, SAMHSA put out a publication called SAMHSA's Concept of Trauma and Guidance for a trauma-informed approach. And this was put out with the understanding of the need to address trauma in a multi-pronged, multi-agency approach. Many of us know that there are multiple concepts and definitions of trauma, and SAMHSA is really working hard on creating an approach that could be acceptable and appropriate and appropriately accessible across an array of service systems. And based on this approach, and as a partnering agency of Trauma Transformed, the Center for the Vulnerable Child adopted these values. And they're based on 4 basic principles. I'm sorry, I'm going to back up one. And these basic principles are based on trauma, stress, reactions, and recovery. And we understand that trauma is common and it's experienced uniquely due to its many variations in form and impact. And we also understand that optimal levels of positive stress can be healthy, but that chronic or extreme stress has damaging effects. We understand that many trauma reactions are adaptive, but that some result in behaviors and beliefs that impede recovery and wellness. And we understand that trauma can be overcome and unhealthy. However, when we understand trauma and stress, we can act compassionately and take well-informed steps toward wellness. We know that trauma is overwhelming and can leave us feeling isolated or betrayed, and this may make it difficult to trust others and receive support. However, when we experience compassionate and dependable relationships, we reestablish trusting connections with others that foster mutual wellness. We also understand that trauma unpredictably violates our physical, social, and emotional safety, and this results in a sense of threat and a need to manage risk. Increasing stability in our daily lives or in our clients' daily lives and having these core safety needs met can minimize our stress reactions, and it allows us to focus on resources or focus our resources on wellness. We also know that trauma involves the loss of power and control that makes us feel helpless. And so we know that when we're prepared for and given real opportunities to make choices for ourselves and for our own care, we feel empowered and we can promote our own wellness. We come from diverse social and cultural groups, and that we know that makes these different groups may experience and react to trauma differently. And so when we're open to understanding these differences and respond to them sensitively, we make each other feel understood and wellness is enhanced. And we recognize the value of instilling hope by seeking to develop a clear path towards wellness that addresses stress and trauma. So trauma-specific intervention programs generally recognize that the survivor needs to be respected, informed, connected, and hopeful regarding their own recovery. Some practical ways to incorporate trauma-informed care can be very basic integration of having staff at all levels of the agency receive training and education on what is traumatic stress, how does trauma impact the body, how does trauma affect attachment, etc. Staff can learn how working with trauma survivors impacts them personally, incorporating regular team meetings on the topic, incorporating time and supervision to talk about their own stress reactions, and then making sure that there is a set system in place to debrief after any crisis that occurs. We also want to make sure that we're creating a safe and supportive environment, like having child-friendly decorations and materials, a space for children to play, a space for consumers to have opportunities to make suggestions about ways to improve and change the physical space. I'm very aware of time, and so I'm going to just go to this last slide and point out some resources for schools. And these resources provide some information on how to incorporate interventions in the classroom, how to support educators if they're needing help on addressing trauma symptoms in a child who is acting out the symptoms in the classroom, creating a sanctuary space in schools, and helping traumatized children learn. Thank you, and I'll pass it back to Julie and Tiara.
Thank you very much, Erica.
Tiara, are you able to see my screen?
Not at the moment.
Okay.
No. Okay.
Okay, so I just have 3 resource slides to share.
Okay.
The first one is from Georgetown University Center for Child and Human Development. They have a huge project to help communities become more trauma-informed, and you'll see on the left side of the screen the list of modules that are part of this project, and each module has several links to other resources, videos, and just a really wealthy resource-heavy website. So the link is at the top. Also, the National Healthcare for the Homeless Council has a webpage on resources for children, youth, and families. You can find that if you go to where that red arrow is on your screen. And there you can download the most recent document on core principles and practices for engaging homeless youth, which was put out this past January. And lastly, if you're interested in signing up for membership, individual membership is free, and you can sign up to receive our e-newsletters to learn about brand new research, new trainings, and available assistance. So we recommend you all to sign up for individual membership. And that's it.
Okay, perfect. Thank you so much, Julie and Erica. We'd like to now offer everyone the opportunity, if you have any questions, please enter your questions in the question box in the control panel. Also, I just want to remind everyone that this is being recorded, and we will upload it to our website in 3 to 5 business days. We will provide the PowerPoint with all these great resources with a follow-up email that you will receive in 24 hours. So right now, we'd like to give everyone a couple of minutes. If you have any questions, please go ahead and enter your questions in the questions box. Also, in our follow-up email, we will provide all the information for the contact information for Julie and Erica. It will also be on the last slide if you want to write it down, but we'll definitely follow up with that information included also. Okay, Julie and Erica, we do have a question. How can we best assist UI when they are under 18 and need regular medical care? Backlash parental consent.
This is Julie. I can recommend a resource from the organization I mentioned during my presentation, the National Law Center for Homelessness and Poverty. They have a huge publication that actually looks at each state and the laws of consent around that. So I don't know if the issue is with consent on the issue on the question that was submitted, or it was about financing the health care. But hopefully that's helpful. I don't know if Erica has anything to add to that.
Yeah, I mean, I think it depends on the state you're in terms of consent, but I wasn't sure also if it was a question around consent or a question around the financing piece. I don't know if there's a way to have a follow-up response to that question from the person who asked it.
Actually, I unmuted that person on Gordon. If you want to speak, I've actually unmuted you if you want to elaborate more on your question. I think as far as, let me see. Michigan doesn't allow UI to consent by themselves. Julie and Erica, were you able to get that?
No.
Did you say
sorry.
Michigan? Something about
yes,
Michigan?
doesn't allow UI to consent by themselves. Consent is, another one saying consent is usually the hardest to get. Most are on Medicaid.
Mm-hmm. I can get those folks, if they want to, if we can get their email addresses, I can get them connected to one of our policy experts that can respond to that particular question.
Okay, I would definitely forward you the information. The mic isn't working at the moment, so we'll definitely forward that information. Another question we have is, how can the teacher have more control in the classroom of students with behavior problems, not homeless but traumatized?
I can answer that question. I think that that's one of the challenges that we see very often, and unless a teacher understands the impact of or the behavior and understands it from a trauma-focused perspective, then they're more apt to actually exacerbate the behavior inadvertently so, and creating more harm. And so I think first and foremost, and this is actually something we're working towards across our school-based health centers and even just across the educational system in Oakland, is first providing education to all school personnel around what is trauma, how does this show up, and what, if a kid is acting out or they are activated and they're acting, for example, aggressively or disrupting other kids in class. We go back to the example of the rider on the horse, and if the teacher is saying, sit still, get in your seat, that's not going to actually help. But very, very basic examples like coming over to the student, not getting in their face, but standing next to them, speaking in a quieter voice, asking if they need to step out for a second. So incorporating the tools that we know that are helpful in bringing the individual back on, or the rider back on the horse, are tools that we are working towards implementing. And it's not something that you can do. It's not like this is one tool that you can use and it's going to work forever. It's a system of interventions that you need to incorporate. So I think first and foremost, I would say providing training to staff around what is trauma and how it shows up, and then thinking together about what are some tools now that we understand how trauma shows up. What are some tools that we can incorporate together as a system when we see a child who is or child or youth who is activated?
Okay, great. Thank you. Sorry, Erica.
No, I was just going to quickly say I also do have a list of interventions, mindfulness tools that I can send out as well, if that would be helpful.
Yes, and I actually have a couple requests for that, so that would be great. We can send those out, and maybe we can add those to the follow-up email too for our
okay.
We do have time for a couple more questions. They're kind of rolling in. Our next question is, what preventive strategies are school-based health centers implementing?
I think that's another really great question. I think where we're working in Oakland and East and West Oakland, we are, again, one of the preventative strategies in terms of not creating more harm is first educating the communities. I think in the past there was a mindset that the professional, providers, the direct service providers were the ones who should have this information at their ready and then incorporate into their treatment trauma-informed practices. And we now know that that is not enough at all. We need to help educate the community, help educate parents, other providers, medical providers, primary care providers, anyone who is having any kind of interaction with youth should be educated. And that's one of the main preventative measures that I think is key.
Okay, thank you. We're going to try to have one more question. We actually have a few questions that are rolling in, and those that we're not able to get to, I would definitely forward everything to Julie and Erica today, so they can follow with you maybe individually. So our next question is, this attendee works with pregnant high school students. The school doesn't have good knowledge of trauma and have no idea how to begin. What do you recommend for them?
There are a lot of trainings that are available, 101 trainings that are available online, as well as connecting with the local primary care associations. And they can always get in touch with organizations like ours that are providing free technical assistance and free training, and we can help set up some trainings for their schools and their communities.
Okay, perfect. Thank you so much. We definitely have a few more questions, but because of time that it's okay, we'll submit everything to you, Julie and Erica, if you can respond to everyone individually maybe to respond to their questions.
Yes,
yes,
sounds
definitely.
Okay, perfect. We definitely want to encourage everyone to just, if you can answer just a few poll questions in response to today's webinar, we definitely want to make sure that we're able to meet your needs in future webinars. So if you can just respond to the first question, did this presentation meet your needs? If you can please take a few seconds just to answer the question. Thank you, everyone. Our next question is, how well did the presentation meet the stated objectives? Okay, and our next question is, how likely are you to apply the information from this presentation in your organization? Okay, and our final question is, would you recommend this webinar to others? And also, if you have any other interesting topics that you would like to hear from any of our partners for School-Based Health Alliance, please email us at any time. And we'd like to thank everyone for answering these poll questions today. And here's the information. Thank you so much, Julie and Erica, for this very informative presentation. We will definitely follow up with everyone that we were not able to get to. And I wish that everyone will have a wonderful day.